Hello, everyone. Dear friends and colleagues in MENA region and outside MENA region. As chair of IDF MENA region, it's really deep pleasure and honor for me to be with you in the second IDF MENA Blue Circle webinar on diabetic foot with the presence and the participation of our IDF President, Professor Andrew Bolton, and expert speakers. I want also to express my great thanks to Professor Nizar, former chair of IDF MENA, who has worked hard with the IDF MENA working group on diabetic food to prepare this program. It's also an opportunity for me to congratulate the IDF MENA working group who have produced two IDF MENA guidelines on treatment of diabetes under the leadership of Professor Abdul Basit, and the second on hyperglycemic and pregnancy with Professor Shabin. I hope with this group of IDF MENA working group on diabetic foot, which will extend it to other colleagues and will produce IDF MENA guidelines on the topic of diabetic foot. At the end of my message, I wish a lot of success of this webinar and thanks a lot our expert speaker from their active participation. Many thanks for all participants and for Amber Events for this important and qualitative organization. Thank you for your attention.
Thank you very much, Dr. Jamal, for this nice introduction and for your support all time for all the working group in the region. And again, welcome for our president, Professor Andrew Bolton. I will not introduce him. He's a very knowing figure, but we will talk about that later. Let me, if allowed me, to start with a small introduction, diabetic foot care. So this one, diabetic foot care committee in the MENA region started in 2019 after Busan IDF Congress. And we have in our committee 4 members. Myself, Dr. Al-Basit from Pakistan, Anan Jawish from Egypt, and Dalal Al-Rumehi from Bahrain. So our committee included 4 people, and after many meetings, we decided that we are going to adopt the IDF guidelines, which was prepared 2 years or 3 years ago. In our opinion, and according to our experience, there wasn't any need to elaborate or to write new guidelines, just to focus on more important things in the region by starting to nominate what we call country champion in diabetic foot care. And from that, we start to build what we call task force for diabetic foot care. Then with this task force, we are focusing now on our real problem in the region to improve diabetic foot care. Now we have at least 5 working subcommittees for data collection, regional challenges and needs, education and awareness, webinar organization, and most importantly, prepare regional studies on diabetic foot care. Of course, this is a very, very important issue and that are missing in our region. So now I believe we have to focus on our real problem in the region more than trying to write again the guidelines, because the IDF guidelines looks really for us as a very adapted for all the region, just to need to take what we need from it. And lastly, we ask every subcommittee to send reports and to organize exchange experience. And this is our second webinar where we are going to present some reports, some experience, and discussion. But we are getting at the end of the day to what we call an expert opinion, map of road or something like that, to trying to deal with what we call specific challenges and needs in the region. We would like to be very practical and to have what we call step-by-step approach in the region. some people suggesting to work with education first, then with national program, then how we can build diabetic foot care in some country where there is no available one. I know in some country like Gulf area, there is a lot of activity regarding diabetic foot, but it's less in the other region like Syria, Morocco, Algeria, and so on. I will not be very long. I will let my co-chair, Dr. Dalal, to introduce the first speaker. Thank you for it.
Thank you so much, Professor Nizar. It gives me great pleasure to introduce our first speaker, Professor Andrew Bolton. He does not need a lot of introduction. Professor Bolton is a graduate of Newcastle upon Tyne who was trained in Sheffield and Miami prior to accepting an appointment at Manchester University. He has authored more than 550 peer-reviewed manuscripts and book chapters mainly on diabetic lower limb and renal complications. He received many awards from the ADA, the EASD, the American Association of Clinical Endocrinologists, and received Georgetown Distinguished Achievement Award in diabetic limb salvage in 2012. And in 2019, he was ranked the #1 UK diabetes researcher in the field of complications. He was the founding chairman of the Diabetic Foot Study Group and was previously chairman of postgraduate education and then honorary secretary program chair of the EASD. Until late 2015, he was president of the EASD, and currently he is the president of International Diabetes Federation and chairman of the European Alliance of Diabetes Research. Without further ado, Professor Bolton, a warm welcome to you from the IDF MENA region, and the mic is yours.
Well, thank you very much, Shukran, for a very nice introduction. A pleasure to be here. Bonjour to my friends de la France, et aussi Maroc, Lebanon, Liban. But I will speak in English for the benefit of our Arabic-speaking population this evening. And it's a pleasure to see many friends there, many people who have been and worked with me for a while in Manchester. So I'm going to take you through a 40-year journey and really to try and emphasize to you the importance of good clinical medicine and how much of my research has been informed by clinical observation, listening to and looking at patients. I started my career, as Dalal said, in medical school in Newcastle upon Tyne, which was famous for neurology. And one of my mentors was Professor later Lord Walton, who is an outstanding neurologist and a clinician. And every week he would emphasize the importance of history taking, and there'd be a large room and a patient would be brought in who he had never seen before from anywhere in the world. And he would take a history and come to a conclusion, but pulling people out of the audience, including medical students, junior doctors, senior doctors, and colleagues. The more senior you were, the more difficult the task you were given. And one day I was at this clinical meeting and he presented this case of a person, a male from very near Newcastle. And he suddenly came over to me with an ophthalmoscope and said, "Bolton, look at the fundi." So I did, and I said, it was a bit tricky, but I said, "I think this patient has bilateral optic atrophy, sir." And they said, "You're right, Bolton, but you look, but you didn't see everything." He said, "Why did you have difficulty looking?" "Because you missed that he's got a pendular nystagmus. And then if you look at his hands, there was bits of black, which was typical of coal miners." He said, "Clearly this man is a coal miner who's been working in a dark area underground, and hence he's got this pendular nystagmus." And that was my introduction to good clinical medicine. And Lord Walton later became a warden of a college in Oxford and died in his mid-90s just a few years ago. And the last time I saw him was at the Association of Physicians in London. And he came up, he said, "Bolton, you've done well. Can you get me some tea, please?" So he hadn't changed at all. So we could say that diabetic neuropathy is the Cinderella complication. And it's quite appropriate. The shoe may not fit, but the patient may not perceive that because they've lost the gift of pain. And diabetic neuropathy is common, up to 50% of older type 2 patients. We've shown in several longitudinal studies it's the strongest risk factor for foot problems, and it's associated with other complications. and it's a symmetrical, length-dependent sensory motor neuropathy. This is one of our early papers 30 years ago, looking at biopsies with my then fellow Aris Vevis, who's now a professor at Harvard, and we can see the difference between the patient with neuropathy and the control, the loss of nerve fiber density in this serial nerve biopsy. And we also demonstrated abnormalities in the capillaries, so microvasculature as well. But this was when I first went to Miami, and this was a case which I'll never forget seeing. I was a young assistant professor in 1983 in Miami, nearly 40 years ago. It was black hair and very eager to see patients. And this patient was sent to me. And his story is unique. And this is published in the British Medical Journal in 1984. And this patient came to us and he said, well, I woke up one morning, I had a bulge, this protuberance in the right side of my abdomen. So I said, yeah, what happened then? He said, well, I called my primary care physician. He said it must be a hernia. He sent him to a surgeon. The surgeon didn't know what it was. He admitted him to hospital. He was in hospital for 5 days, numerous tests, endoscopy, barium enema, barium meal, ultrasound, intravenous parallelogram. But nobody actually spoke to the patient and took a good history. So after this, the surgeon said, well, I'm not sure what's going on here. He said, oh, I see he's got type 2 diabetes. Let's send him to the Diabetes Research Institute in Miami, where I was working with my good friend Jay Schuyler, and I saw him as a new patient. So I said, if you had this swelling in the side, did you notice anything else? He said, well, the night before, it was very uncomfortable to sleep because on the right side, I had this burning pain. Aha, clue. So then I examined the patient, and he did have weakness in these muscles, but he had absent abdominal reflexes. And allodynia, which is a non-noxious stimulus giving rise to a painful experience, in about T6 to T10 on the right. So I thought this is probably an unusual presentation of a polyradicular neuropathy. One EMG in the diagnosis was made, fibrillations, abnormalities in rectus abdominis muscles. So this is a history of how history taking is important. And the most important thing for junior doctors, medical students working in the diabetic foot especially, is don't only listen, but hear what the patient says. Don't only look, but see. And that's the message throughout this talk. Now, prior to that, I was working with my mentor and later very good friend, Professor John Ward, who we made this observation of these dilated dorsal foot veins in the feet of patients with foot ulcers. But not only the ulcerated side, but the contralateral side too. So what could this be? And we felt it was probably due to arteriovenous shunting with a sympathetic neuropathy, release of tone, increased blood flow, and shunting. So we described this physical sign of autonomic neuropathy in the diabetic foot in 1983. But the year before, we did a study where we actually sampled the blood here, and if there was arteriovenous shunting, we'd expect this to be oxygenized. And what we showed in this paper published in January 1982 was that neuropathic diabetic feet are warm as a consequence of sympathetic neuropathy. We sampled blood from these veins, and the venous PO2 was almost arterial levels, very high in the feet of those with a history of foot ulcers, compatible with arteriovenous shunting. In the same issue, back to back, was a paper from my friend Mike Edmonds, long-term friend who you'll know of at King's College Hospital, and he had published in the same issue non-invasive studies using Doppler studies and showed these abnormal blood flow profiles or sonograms in severe neuropathy, and those with a history of foot ulcers, increased diastolic flow, suggesting arteriovenous shunting. So that was one of our first observations, and it came from listening to patients, what they had to say, and looking at them and taking the research there forward. So the warm but insensate foot is very much the foot at risk of ulceration. Then in 1985, I first visited India to what was then Madras, or now Chennai, the Indian Institute of Technology, where we presented some of our work on the diabetic foot in a conference on the International Conference of Biomechanics and Clinical Kinesiology of Hand and Foot in Leprosy and Diabetes. And that's where I had the pleasure of meeting the late Dr. Paul Brand. And here's a photograph a number of well-known people in this photograph. This is Wagner. You've heard of the Wagner, not the composer, by the way. This is Wagner, the orthopedic surgeon, whose Wagner classification of diabetic foot ulcer. The late Roger Pecoraro, who did much work in the area. This is Lee Sanders, the first podiatrist and president of ADA. Marv Levin, first textbook on the diabetic foot. Gail Reiber there. Larry Harkless, the king of podiatry in the USA. And there's the late Dr. Paul Brand, who had been a missionary working with people in leprosy and later diabetes. And sadly, on the far left, that was me 30 plus years ago, and it shows you the dangers of working in the diabetic foot for too long. So Paul Brand said, any patient with a plantar ulcer who walks into the clinic without a limp must have neuropathy, clinical observation. And he said that pain is God's greatest gift to mankind, and he was right. And he said, when I started seeing diabetic ulcers, it reminded me of leprosy ulcers. He said, these are not diabetic or leprosy ulcers. They're not directly caused by diabetes or leprosy, but as a consequence. In diabetes, neuropathy, and leprosy, nerve damage, not the infection itself. Nerve damage by the bacilli, Mycobacterium leprae. So he said, these are trophic ulcers, not diabetic ulcers, not leprosy ulcers. And it's not the disease itself, but neural damage that leads to ulcers that you see, particularly in the MENA region. The majority of ulcers you will see will be neuropathic and increasingly, sadly, neuroischemic. So an early study we did when I first moved to Manchester, I moved there 35 years ago, and we opened a new diabetes center in 1988. We screened a large number of patients there, just using the loss of vibration perception assessed by the biaesthesiometer as a mark of neuropathy. They all had the routine education. They were followed for 5 years. And you're familiar with the biaesthesiometer. This is a vibrating stylus. You crank this up, the higher the reading, the more severe the sensory loss. And the results of this study confirmed, because everybody said diabetes causes foot ulcers by neuropathy, but it had never been shown in a prospective study. So we showed it. VPT, vibration perception of more than 25, is definite neuropathy. And the risk per patient per year of developing a foot ulcer was just about 1 in 20 or 5%. 7 times higher than those without neuropathy. So neuropathy plus something else, usually trauma, unperceived trauma, is the cause of ulcers in many cases. So another one of Paul Brand's contributions to diabetes was measurement of pressure. He did very early foot pressure measurements, and we presented some of ours from Sheffield when I met him in Madras back in 1985. And here he is in his very early studies. Nothing is new in medicine, it's rediscovered. His very early studies published in 1963. And pressure is the critical quantity that determines the harm done by the force. And these crude transducers back 60 years ago, or 70 years ago, almost 60 years ago, showing the problem there. Well, in 1999, we confirmed that the simple tests, similar to the Harris mat, but cleaner, the pressure stat, can be used to demonstrate areas of high pressure under the neuropathic foot. And this can be used as a patient aid. Give this to the patient. They're very cheap. You walk across it, you can tear off. You've got a pressure contour map of the footstep. And you can show the patient, look, these darker areas, as you see here under the 4th and 5th metatarsal head and the hallux, these are risk factors, risk areas. Look at them each day. But of course, we have much more sophisticated devices now. And this is the EMED, for example, one of them. We did a lot of studies using the optical Peter barograph. But this summarizes studies in one slide that I did over 10 years in Sheffield and Manchester. We showed that high foot pressures are associated with first and recurrent ulcers. The foot pressure abnormalities precede the appearance of neuropathy. That high foot pressures predict ulcers, and that plantar callus leads to high pressure. Debridement reduces pressure. So much more recently, we've done more studies looking at force plates, gait, balance in patients with neuropathy. And work done by my wife, Dr. Loretta Bilikite, has shown that diabetic neuropathy patients are up to 15 times more likely to fall, to be unsteady, because of loss of proprioception, large fiber function, as you know. And unsteadiness is a major symptom of neuropathy that isn't in many of the older textbooks, but it is now, I can assure you. Neuropathy is an independent risk factor for falls, and of course, it's the sensory, proprioception, and motor, altered pull for the flexors and extensors, for example, in the foot. So lower limb biomechanics are very important. And working with my colleague, Professor Neil Reeves, over the last 10 years, who is an expert in biomechanics, and we've got a gait laboratory in his laboratory where we can actually measure sway and balance walking up and down stairs. And if you think about it, most falls occur not when you're walking on the level like here, and these are pressure sensors here, but when you're going up and down stairs. So we have, this is Professor Neil Reeves tagged up with a number of reflective markers with cameras throughout the room, and we could look at gait. And you can see here a camera system where we can look at gait and sway, AP, and anterolaterally as well. Now, I hope this works, but it should work. Yes, it's working. Here we are. So there's the, I'll go back. There's the control, normal person walking down the stairs. Here's the patient with diabetic neuropathy, much more sway and steady, and using the arms to balance. So in a series of studies, I haven't got time to go through them, but we've demonstrated the mechanisms that underpinning falls, the rate of joint torque or muscle strength development, how people's visual gaze is disturbed because they can't feel, so they're looking down and walk very deliberately and slowly. We've demonstrated a higher metabolic cost of walking in diabetes. We're looking at the role of the Achilles tendon and perhaps how targeted physiotherapy might help in these people with poor balance. And the last study we published in Lancet Diabetes Endocrinology, Lancet Digital Health, 2019, where we took this using smart insoles. And I've already shown you our early studies that foot pressures, high foot pressures, and the neuropathic foot are risk factors for ulcers. But can we investigate the efficacy of pressure sensing smart insoles to reduce foot ulcer recurrence? And this is the insole here that's a number of sensors in it, and it reads straight by wireless Bluetooth to a wristwatch that doesn't show the time, but shows your feet. And if there's a high pressure area, it will vibrate, and the patient can be told that there's very high pressure under a certain area of the foot, and they can rest or alter their gait. And what we showed was that recurrent ulcers were reduced by 71% in those randomized to active, the pressure sensors reporting back to their watch. And this is patient empowerment and the measurement mechanism, of course, by readjusting pressures when you're walking. So I'll leave you with a few thoughts. One is that the trouble with most doctors is not that they don't know enough, but they don't see enough, said Corrigan, whose collapsing pulse of aortic incompetence was his sign. This is true. And the message here to conclude is good clinical medicine is crucial in the diabetic foot management still in the 21st century, especially in the time of the COVID pandemic, where we often can't do tests. A good history, don't just listen but hear, a thorough examination, don't just look but see. So Professor Lindsay was right, Professor of Medicine in Belfast, who wrote these words, for one mistake made for not knowing, 10 mistakes are made for not looking. And I forgot to put the slide in, but please don't forget, and perhaps someone else will have this, or Jamal will mention it at the end. We have our IDF Complications Congress in December. Do submit abstracts. There's a special stream on the diabetic foot, and this is going ahead in December virtually, sadly. We look forward to welcoming many of you to this conference. There are very low registration rates, especially for people from low and middle income countries. And we look forward to sharing this update on the diabetic foot and neuropathy with you there. Shukran, merci bien, and thank you very much.
Thank you so much, Professor Bolton, for your fantastic talk. And we will take a couple of questions. We understand that you have time constraints and you will have to
Sadly,
leave,
I cannot stay because I've actually got a spondylolisthesis and a bad back, so I'm not supposed to sit around for too long.
We sure hope you feel better soon. Dr. Nizar, do you want to go first?
Yeah, excuse me, I have a question, please. Regarding the early diagnosis of diabetic peripheral neuropathy, there's always an advice to use monofilament. But in a lot of study, we find now that is not enough for really discover and diagnose all cases of peripheral neuropathy. What is your opinion about the best tool to diagnose early peripheral neuropathy according to your experience?
That's a very good question. And there are two things here. First of all, are we diagnosing neuropathy, or are we diagnosing neuropathy at moderate to severe level? In other words, the high-risk foot. The monofilament is good for the latter, but it's not good for early neuropathy. For early neuropathy, more sophisticated tools are needed, and perhaps a simple neuropathy disability score where you've got small fiber tests such as pinprick, heat, a large fiber vibration plus reflexes is better, and we've used this in larger studies. But for true diagnosis of early neuropathy, when we have a pathogenetic treatment, we're going to need more detailed quantitative sensory testing, I think, for small fiber function.
Thank you.
I wonder if someone else from the panelists has a question. If not, I will move ahead with one. So, Professor Andrew, how much of patient empowerment is helpful? What programs, in your opinion, are the most succeeding in making patients seek care early on, before the damage is done?
Well, I think the answer to this is seeing is believing, and patients can't see their own feet. So we're working at the moment, from my wife Loretta and myself, with our connection with the University of Miami, looking at tools where you can have a pressure and a temperature sensitive mat that gives the patient via an app, so they can actually see their own feet, and they can see if there's a warm area that's at risk. And I think if patients can see, it's not, education is good, but not alone. And studies sadly have shown that education alone is not sufficient. And I think you need education plus the patient's intervention. So, for example, my friend Larry Lavery in the States showed that if you've had a foot ulcer in the past and you monitor skin temperatures, as well as checking your feet, and one foot's warmer than the other, and you stop walking, then you stop an ulcer from developing. So it's understanding, but also empowering the patient to be able to do something themselves, even if it's just a mirror. But now we're getting more sophisticated. And, you know, I go to India a lot, and I'm told that people are more likely to have a cell phone than they are to have a toilet, which is incredible. Everybody's on the phone all the time. So I think across the world, this kind of education and feedback to the patient is going to become much more available. And we've learned there's no good things to come out of COVID, but one thing that's been forced upon us is advances in telemedicine, and this is one of them.
And we have questions from our attendees. There's a question: is offloading better in the early part of diabetes management?
Offloading is the best treatment for a neuropathic foot ulcer. And people often ask me, what should you put on the ulcer? I said, it's what you take off the ulcer that matters. Debridement of callus and pressure, because the patient will walk and they cannot feel. I had a patient just last week. Well, it doesn't hurt, you know, even though I've been going through the fact you can't feel pain. So you've got to get this point home. So offloading is key in the Charcot foot, in an active foot ulcer, but also with good shoe gear to be used after you've had an ulcer to help redistribute pressures and give protection.
And perhaps we take one last question. There is a question about your opinion about the pseudoscan or pseudometer test in diagnosing diabetic polyneuropathy.
Well, you know, as I say, if you want to use expensive equipment, you can do. But the most important thing, when Paul Brand was lecturing to an audience in America where he worked, what's the most important thing we can do to reduce amputations? They were expecting expensive tests. The most important thing you can do to reduce amputation is to remove the shoes and socks and look at the feet every time you see someone with diabetes. So it's careful inspection. There are simpler tests to test for sweating, such as the Neuropad, for example. I mean, the pseudoscan is useful, but it's expensive, and most healthcare systems can't afford that.
Thank you so much. And I don't know, Dr. Nizar, do you have any last questions or thoughts?
I believe this is the most important questions among our attendees. I believe I agree completely with Professor Bolton. in developing countries, we need to make diagnosis very early using simple tools, very expensive tools. Even in France, where I'm working now, we don't use it every day. We use our clinical judgment, sample tools for diagnosis. And again, the most important take-home message from this presentation, clinic is first, clinic is second, third is clinics. Look and see and take your time.
D'accord.
This is my opinion. I don't know. I agree completely with them. I believe this is a good message we got today. Thank you again, Professor Burton, for this very, very rich and interesting presentation.
Sorry I have to leave, but I'm sure you'll have a very good meeting. I know the speakers are all excellent.
Okay. Nice to meet you, to have you today.
Au revoir, bonne nuit.
Thank you. Bye-bye. Bye-bye. Thank you. Au revoir. So, if you allowed me, I will present the next speaker for today. Yeah, so it will be, yeah, I don't have the program. The next speaker will be, the next speaker is Dr. Amal Madanat from Jordan. She is going to talk about a very important issue, which is challenges and needs of diabetic foot care in the Marian region. She's probably going to present the regional report on challenges and needs. Dr. Amal, the micro is yours. Please, you can start.
Mr. Chairman, dear colleagues, it's my pleasure to present to you today at this important scientific meeting. And my talk will be about diabetic foot care in the MENA region in terms of challenges and needs, and will conclude with initiatives. Now, diabetes is one of the greatest health challenges of the 21st century, being not only a chronic major public health problem, but because its prevalence is on the rise. The greatest rise after Africa by 2045 is expected is in our MENA region. Consequently, diabetes-related complications are expected to rise, including lower extremity complications of neuropathy, foot ulcer, and amputations. Arguably, the most disabling of these complications are lower extremity complications. A recent study demonstrated that the global disability burdens of diabetes-related lower extremity complications measured using years lived with disability is on the rise too. Here shown that globally, the years lived with disability of neuropathy in blue, of foot ulcer in orange, and amputation has risen in 2016 by 16.7% as compared with 1990. In the year 1990, the highest affected areas were Central Latin America, MENA region, Oceania, and the Caribbean, while in 2016, the most affected area on the top of the list is the MENA region with 13.7% increase. Furthermore, the same study showed that years lived with disability of neuropathy occur in the age range of 50 to 59, and there was no gender differences. However, for foot ulceration and amputation, the age range between 16 to 69, and there was male preponderance. Furthermore, lower extremity complications are associated with increased mortality and with huge economic burden. This study from the US showed that the annual direct cost of limb complication, both of peripheral vascular disease and neuropathy, surpasses the cost of the 5 most costly cancers in the US. This is another study from Qatar published in 2019 and showed that the healthcare cost of amputation and prosthesis are very high and is more than $26 million in one center. Meanwhile, most of the countries of the MENA region have limited economic resources. Now, the IDF timely responded to the challenge. However, at the level of individual countries of the MENA region, this trend in diabetes and its complications was not faced with appropriate policies and actions and investment. So we can see lack of diabetic foot prevention programs, lack of adequate healthcare provision based on interdisciplinary foot care services, lack of access to orthotics and podiatry services, although there are good initiatives implemented in few specialized centers such as Kuwait, Egypt, Pakistan. In general, the situation is poor. Furthermore, there are no reporting systems such as registries for amputations to allow the assessment of the magnitude of the problem, nor to allow the evaluation of the effectiveness of an intervention. With regard to research and data on diabetic foot, there are some studies on various aspects of diabetic foot. However, most of these studies, they include limited number of patients and are from single centers. In the MENA region, there are huge differences in the level of general healthcare provision between urban and rural areas, and patients with diabetic foot problems need to travel long distances to reach for care, and they incur additional expenses, and this results in delay in timely medical care. As you all know, over the past 2-3 decades, there is an increasing number of refugees in the MENA region as a result of political instabilities and warfare. And this increases the economic burden on healthcare resources of countries of relocation. Refugees with diabetes suffer more because they lost their regular diabetes care and medicine supplies. And as you all know, poor control of diabetes increases the risk of complications, including diabetic foot disease. Now, in the MENA region, there are also certain factors that worsen the situation, such as illiteracy, fatalism, and peculiarities. This leads to misconceptions about healthcare, widespread use of traditional medicine, delay in seeking timely professional medical care, barefoot walking habits and hot, dry weather, wearing open sandals, leave the feet at increased risk of dryness and traumas. People often neglect drying their foot after wudu as a preparation for prayer, which increases the risk of infection. And we are now faced with an unprecedented challenge, the COVID-19. This pandemic resulted in changes in healthcare system, shifting of healthcare economics resources toward the fight against the pandemic. Furthermore, lockdown and social distancing resulted in decline in follow-up visits of patients with non-communicable diseases, including diabetic foot problems. It disrupted the available practices for diabetic limb preservation, leaving huge number of patients without care. Needless to say, worsening of socioeconomic status of people and governments. So how to face the challenges? We'll start with the COVID-19. To address the burdens of COVID-19 on the care of patients with diabetic foot, we can refer to recommendations for the care of diabetic foot patients in COVID-19 times of the IDF International Working Group on Diabetic Foot. The priority recommendations for clinicians are to help their patients to stay both free of hospital and COVID-19, ensure widespread vaccination. There is a need to rearrange services and to determine which patient need hospitalization through a triage system. As you can see, only 0.25% of patients are critical and need hospitalization. Those with severe and some moderate infection, with gas gangrene, with sepsis, with acute limb-threatening ischemia. Less critical patients account for 0.75% of patients with diabetes. They have mild to moderate infections, including osteomyelitis, chronic limb-threatening ischemia, dry gangrene, worsening of foot ulcer, active charcot foot. These patients can be managed in an outpatient clinic office-based lab, surgery centers, and podiatrist office. Now, 3% of the patients with diabetes, they have improving foot ulcer, inactive Charcot foot, not yet in stable footwear. These patients can be managed in podiatrist office and through home visits, through telemedicine. While the majority of the patients, about 94% of them, they have uncomplicated venous leg ulcer, recently healed foot ulcer, inactive Charcot foot, unstable footwear, and healed amputation, or for diabetic foot risk assessment. These patients can be managed through home visits or telemedicine. Now, to prevent diabetic foot problems, we need to prevent diabetes at the first place. Professor Joslin, 100 years ago, he published an article and stated there are probably more than 500,000 diabetics in the United States. Therefore, it is important at the present time to devote attention not alone to treatment, but still more, as in the campaign for typhoid fever, to prevention. The result may not be quite striking or as immediate, but they are sure to come and be important. We need to establish a national diabetes foot control program that should be integrated in the National Diabetes Control Program. Through this program, we need to mobilize efforts of professionals from across the country, from across different sectors, diabetologists, orthopedic surgeons, nurses, paramedics, podiatrists, pharmacists, IT specialists from governmental and private sectors, medical colleges, and local diabetes care societies. And any diabetes foot control program should be culturally sensitive, taking into account the peculiarities, beliefs about health and illnesses in the society, and special care should be provided for vulnerable groups, diabetic patients with poor sight, on dialysis, with disabilities, women, patients in rural areas, illiterate, and refugees. Until this happens, there is a need to design and implement IDF MENA region initiative to assist the countries of the MENA region to control diabetic foot disease. These initiatives should have well-defined goals, be simple to implement, and sustainable. They should have measurable outcomes pertaining to the ultimate goal of decreasing the occurrence of amputations and its sequelae, such as rate of amputations, rate of foot ulcers, hospitalization, death related to diabetic foot disease, and economic burden. Examples: IDF MENA region initiative to create national amputation registries. IDF MENA region initiative to design and perform multi-center studies where all countries of the MENA region be involved, so that the data will have the power. IDF MENA region initiative to create diabetic foot care teams with subsequent establishment of diabetic foot clinics. And this can be realized through identifying a diabetes care center of excellence, where training courses can take place, and the curriculum would be based on the International Working Group on Diabetic Foot. And these training courses would be modified to meet the COVID-19 recommendations time, such as step-by-step training the trainer. Mobile clinics are good option to reach refugees and patients in the rural areas. So to attend these training courses, we can invite 2 nurses, 1 physician from hospitals across the country. After completing the course, they can go back to their hospitals and establish diabetic foot care clinics, and then they can engage in continuous medical education and keep contact with their tutors. Furthermore, we need IDF MENA region initiative on educational programs to empower patients and their caregivers on foot care. Furthermore, we need educational programs to empower healthcare providers on preventing diabetic foot disease based on adherence to international guidelines on feet examination, screening for early detection of diabetic peripheral neuropathy, implementation of multifactorial risk reduction interventions. Now, the international guidelines are consistent with their recommendation and advocate the inspection of the feet at every visit and the physical examination of the feet at the diagnosis of type 2 diabetes and then annually, and after 5 years after the onset of type 1 diabetes and then annually, with emphasis on vascular assessment and neurological examination. For small fiber neuropathy, using pinprick and tip therm. For large fiber neuropathy, using touch sensation, vibration perception, and the achial reflex for motor function. And to assess the risk of foot ulceration, we use the monofilament. If there are no instruments in some places, we can utilize the Ipswich touch test, where you don't need any instrument, just to apply light touch on these 6 points, and we don't poke, we don't prod. If you have 2 or more missed sensation points, this means that there is a loss of protective sensation and there is increased risk of foot ulceration. We published data on the performance of Ipswich touch test against the vibration perception threshold and showed that the sensitivity is 85%, specificity 92, area under the curve is 0.9. And against the monofilament, the specificity was 98%, negative predictive value is 90. So it is a reliable test to detect the risk of foot ulceration in our regions. Furthermore, there are challenges with the current screening recommendations of the international guidelines. Screening for diabetic peripheral neuropathy is commonly overlooked due to lack of time, lack of resources, lack of training. And bedside tools are operator dependent and not reproducible. They are able to detect diabetic peripheral neuropathy when an irreversible damage for microvessels and nerve fibers had already occurred. So now what we are doing is we are looking for the risk of ulceration when the nerve damage is already there and we are very close to the amputation. What we ought to be doing is to look earlier. We need to detect the neuropathy early because the feet at risk, 78% of it is due to peripheral neuropathy. So we really need to have objective biomarker to predict complications early. For diabetic retinopathy, we have the digital retinography that really decrease the occurrence of blindness. At least this is published in the UK. For diabetic nephropathy, we have the microalbuminuria that defer the occurrence of macroalbuminuria. But for diabetic peripheral neuropathy, we don't have objective marker to predict the occurrence of diabetic peripheral neuropathy early. Now, Wiseman et al. Conducted a study and followed 125 patients for 5 years, and they were without clinical neuropathy. After 5 years, 25% of them developed clinical neuropathy. And she shows that using individual or simple combination of nerve conduction study parameters are valid measures to predict the occurrence of diabetic neuropathy early. But the problem is we have millions of patients. Are we going to perform these tests for all the patients? The answer is no. But with the introduction of objective point of care devices that are quick, invasive, like DPN check, that measures the velocity and the amplitude of the sural nerve to detect large fiber neuropathy in the clinic within 2-3 minutes. Like pseudoscan that measures the function of the small C fibers and autonomic neuropathy, also very quick and can be done at a point of care. Now, because DPN involves both large fiber and small fiber, there is a good rationale for combining DPN check and pseudoscan to screen for generalized DPN. This concept was...
Dr. Amal, please, for problem of time, maybe we shouldn't exceed 1 minute more than the according time. So please, if you...
I'm within 20 minutes. Yes.
This is okay.
Yes, I'm sure.
Okay, please. Okay.
This concept was tested by Binshall et al., and they showed that the combined testing is sensitive 94%, area under the curve 88%. So to overcome non-adherence to screening and late diagnosis, they proposed a one-stop screening vascular for microvascular complications to include screening for retinopathy using digital retinography, screen for nephropathy using microalbuminuria EGFR, screening for neuropathy using combined DPN check and pseudoscan. And they proposed if the patient is found to have a neuropathy, he can be screened in 2 years. If he is diagnosed with neuropathy, then we can apply 10-gram monofilament. If there is increased risk of foot ulceration, he is referred to foot protection team. If negative, he is referred to intensive risk factor intervention if unclassified to annual screening. Now, Selvarajee et al. Further advanced this proposition that one-stop screening test will include not only microvascular screening, but for macrovascular screening, blood pressure, lipid profile, non-alcoholic fatty liver disease using FibroScan, and the quality of life. Now, these propositions have to be validated on large scales, but one-stop microvascular screening might be tested in the MENA region. Until further evidence, we need to adhere to the current international guidelines. Implementation of the IDF MENA region initiatives, as Professor Joslin stated 100 years ago, the results may not be quite striking or as immediate, but they are sure to come and be important. After all, we don't want our future colleagues after 100 years to say that we did not respond to the challenge. And thank you for your attention and stay safe.
Thank you very much, Dr. Amal, for this very nice and practical talk. For the question, we will probably get all the questions at the end of this session. So for now, yeah, thank you very much. Please stay with us for the questions. And I will let Dalal to present the next speaker, please.
Thank you so much. So now we will present Dr. Hanan Gawish, who is a professor of diabetes and endocrinology, the secretary of Pan-African Foot Study Group, secretary of International Diabetes Federation Diabetic Foot Consultative Section. She is chair of the Egyptian Society of Diabetic Foot and secretary of the International Diabetes Federation Foot Consultative Section in Egypt. Dr. Gawish had successfully managed the step-by-step project for the prevention of diabetes amputation in Egypt between 2007 and 2010. She is a representative of the International Working Group of Diabetic Foot, board secretary of the Society of the IDF Diabetic Foot Consultative Section, and chairperson-elect of the Egyptian Society of Diabetic Foot and board secretary of the Pan-African Diabetic Foot Study Group. Dr. Hanan, we look forward to your talk.
This presentation is not actually introduced for those who are interested in diabetic foot or for those who are experts in diabetic foot. No, I'm talking to people who are interested to have a foot care clinic implemented in their countries and they didn't have it before. The patient education is very important. When we started our first research on diabetes clinic about the prevalence of risk factor, we found that the highest risk of diabetes, diabetic foot problems was the lack of education by the patient. We asked our patient if they have any education about their foot before, and we found 93% of them was not having this simple message of washing, drying between fingers, using emollient, what about the footwear, the therapeutic footwear, and so on. Why is this lacking? To my mind, that was year 2005 or 6 when we installed our first foot clinic in Egypt. Because of the lack of nutritionists, diabetes educators, and podiatrists, physicians are overwhelmed with a lot of things to talk to the patient about, so they usually forgot the foot. And this is why this patient, no one has told her not to put her feet into warm water before any other one testing the temperature of the water for her. And no one, for example, have told this patient not to sleep beside a heater, and she came out with burnt toes like this. It's not only a problem with patient education, there was also a problem with physician education in Egypt. By year 2005, the greatest barrier we found in Egypt, and I'm sure this is the greatest barrier among the MENA region, is the definition of diabetic foot. Although the WHO definition of diabetic foot is clear, and Professor Bolton has a definition that any foot pathology that results directly from diabetes or its long-term complication is a foot pathology, I don't know why, for some reason in our region, the diabetic foot is usually resorted to gangrene, gas gangrene, amputation, pre-amputation, and so on. And by that definition of diabetic foot in mind, diabetic foot was completely a surgical problem until 2005. And we found a great resistance that a foot clinic should never be implemented in a diabetes setting. And this will be the situation in any country who does not have until now a foot clinic. And the resistance go down with each clinic after that. But the first clinic who are going to be installed, this is a big, big barrier. But if you show the policymaker at your department that a simple lesion like this is a callus from badly fitting footwear, and if you have a foot clinic in diabetes setting, this callus could be removed like this. And with advice about the footwear and advice about emollient and so on, you can get the feet of your patient for life. But unfortunately, because this is of no interest to a surgeon, and this is of no problem to the patient, he decided when he had such lesion on the other side to remove it by himself, and that was a catastrophe of infection, osteomyelitis, and amputation. And this is why the foot clinic should be present in every diabetes settings, because there should be someone who cares about such minor lesions as, for example, these fissures before it leads to massive infection like this. This is severe infection that might lead to amputation. One of the barriers also for physician education is the policy making, because in our region, as in any other developing countries, the policy is usually towards therapeutic rather than preventive. And as an example of that, since 2 months, I have had a good news in one of our newspaper called Dustur, that we are about to have initiative in Egypt for proper feet to prevent diabetic foot from amputation. So the title was very great to me, and I passed through reading that, and I found it turns out to be very bad news that Egypt is about to have a factory for prostheses, and they need each one to register who needs prostheses. So patient education, we have a problem. Physician education, we have a problem. Medical student education too, we have a problem, because we found that the curriculum of medical student was lacking foot examination and value of screening. And we have installed that many years before. And we are very, very happy that we did that to our country, because later we are going to have one day all types of physician, all specialty of physician who understand what we are looking for. The second thing is that we as medical students, we were never taught Charcot except as a chronic deformed bag of bone Charcot. No one has talked to us about acute Charcot. And this is a presentation of Charcot to Mansoura Foot Clinic year 2008. By that time, we have only 20% of our patients as acute Charcot, and these were usually diagnosed by our clinic. But 80% of patients, as you see, were already having chronic Charcot or coming with activation on top of chronic Charcot. And this is an example of why when you stop teaching Charcot for medical student or postgraduate internist, except as a bag of bone, that we reached like this patient. She was not having plantar surface to walk upon. She was walking on her lateral malleoli. And this has been the management we done, which it took us months and months to wait for her role in our orthopedic surgeon and to have governmental coverage for this Elizarov technique. And finally, we were able to have plantar surface for this patient and heal her lateral malleoli. But this is not the case for every case. How many times you see a very advanced chronic Charcot that you or the best center in the world cannot do anything except amputation just because we do not know about acute Charcot. So public awareness is also defective, and I consider it part of our education. For those who are interested to start, where to go to start? There are different ways. The best way for me, and this is my advice for our group member association of the MENA region, is a step-by-step project for prevention of amputation that we adopted in Egypt many years ago. This module is conducted by India, first conducted by India and Tanzania, then copied by Egypt, Sudan, and Pakistan before us. The model includes the training of physicians and nurses from across the country to be widely spread again across the country. A basic course is usually concerned to develop a minimal model foot clinic about prevention and basic curative care. We advise them to just care about their own patients in their own diabetes settings. And we give them basic equipment needed for this foot screening, risk categorization, and handling the minor problems with the foot. And after 1 year, we met again after working, and we have the advanced course. In the advanced course, they learn more about Charcot, PAD, peripheral neuropathy, how to treat diabetic foot ulcers, infection, and so on. And we report the data as mentioned, as the group of Pakistan, you have to register for the World Diabetes Foundation as a sponsor, the number of feet you have screened and what you have found and so on. We give them also educational illustrative material for the patient in Arabic and videos and books for a physician in English. And we meet them 1 year after, that was year 2009, to have our advanced course. Some of this minimal model spread now across Egypt. They were 30. They have now grown up into intermediate models. And some of them have also grown into a center of excellence. One of the beneficial things that happen around the step-by-step project is that according to the need of the sponsor to the World Diabetes Foundation, you need to contact different media, newspaper, radio, TV, and we were present by that time on different newspaper and on the different TV shows and radio show. And this increased the public awareness across the country. So it's a simple project, only education of multiple teams by us in Egypt. We're 30 teams by different countries. It depends upon your population. And one of the byproducts we have from Step by Step is that together with the people we have worked together for 3 years to collect our data, we have developed the National Society, our Egyptian Society of Diabetic Foot. This is one of the best things that happened as a byproduct of our step-by-step project. And I'm very honored to show you the website of the Egyptian Society of Diabetic Foot. Today, I found that the number of visitors to our website is now more than 1,300,000 individuals. Our website goes in Arabic for our patients, and we receive questions from them, and we have a lot of educational material on our website, and it goes in English for physician and interested individual. So if we talk about the value of the Egyptian Society of Diabetic Foot, it keeps the wheel spinning through different training program, workshop. We have a national conference each year. Last year was a webinar online because of COVID, but it usually have people from different countries among the MENA region sometimes attend our meeting. And we tried usually to increase the public awareness. So success is a journey and not a destination. And I think that we enjoy the journey, and we are willing to exchange our knowledge with other people who are willing to install step by step in their countries. In conclusion, there is educational defect. No worries about that, no wonder about that, about the foot among patients, among students, among primary healthcare, and even specialized internists. And my advice is that step by step as a model is very successful and needs to be implemented in other countries in the MENA region where they do not have foot clinic in diabetes settings. Before us, we have a lot of foot clinic, and we are still having a foot clinic everywhere across the country that belongs to the surgery. So it's very easy for every diabetic patient, for example, to go for amputation in a university hospital, insurance hospital, private sector, by orthopedic, by vascular surgeon, by surgeon. It's very easy. But it was not as easy to have the foot care in Egypt before in his diabetes setting that he attends. And some of diabetic foot centers of excellence, as the one I've been working in Mansoura or Bakai Institute in Pakistan, these are centers. They are doing every effort to overcome every barrier, and they do not stop. As we see, they are working now on footwear projects and different projects and so on. And these centers, I'm sure they are ready to translate their knowledge to patients, to physicians, to nurses through different educational courses. And we are willing also to help other countries in the MENA region or anywhere in the world to develop step by step in their country. And I'm very honored to have done this with a Nigerian professor of endocrinology that have now already step by step installed in her country. Thank you so much for that.
Thank you very much, Dr. Hanan. Really, what you have done in Egypt is a good job, very interesting. And personally, I assisted one workshop in your center.
Yes.
I admire what you did. You know, my colleagues from France also were surprised to see how was really your center prepared for everything. So good job. Thank you for this effort for diabetic people in your country. We can now present Dr. Yes, please, Dr. Abdul Hussein Marzouk from Iraq. He is a consultant surgeon in fracture and orthopedic at Al Fahia General Hospital, Basra, Iraq, lecturer orthopedist and College of Medicine, Basra University, chief of orthopedic department at the Al Fahia Hospital, Iraq. He is going to talk today about how to avoid the amputation of diabetic foot. Please, Dr. Abdul Hussein, it's up to you to start, please.
My talk about how to avoid amputation in diabetic foot patient. I am Dr. Abdul Hussein Marzouk, consultant orthopedic surgeon from Basra, Iraq. First, we talk about overview. First, a good level of clinical skill to manage these high-risk individuals. Second, organize and systematic approach to ensure effective and sustained healthcare delivery. Third, diabetic foot care program. Fourth, increase awareness of both patient and healthcare staff. 5, identify high-risk group with peripheral neuropathy, peripheral arterial disease, diabetic foot ulcer infection, deformity, Charcot disease, and treat them. Treatment for overview treatment by multidisciplinary team approach, control of blood sugar, wound care, control of infection, pressure offloading, maintain blood supply. There is every 20 seconds someone is amputated to diabetic foot. After a major amputation, 50% of people will have their other limb amputated within 2 years. The relative 5-year mortality rate after limb amputation is 68%. Thus, amputation not solve the problem of diabetic foot. We first control of blood sugar. The best indicator is glucose. Control over a period of time is hemoglobin A1C. Hemoglobin level above 12 is associated with decrease in neutrophil function, including leukocyte chemotaxis, high potential for suppression, inflammatory response, and decrease host response. This is a multidisciplinary team group of specialists and technicians working together for treatment of diabetic foot. Diabetic foot is like iceberg, only a small part is visible. We need to promote the role of primary health care in diabetic foot screening, sensation, blood vessel, deformity, area of pressure, footwear infection. We should be classified the alternative risk annually, check every patient with diabetic in diabetic foot clinic for follow-up. First, if there is no neuropathy, this is a risk factor absent and should be followed up yearly, while a patient with sensitive neuropathy is a medium risk and should be every 6 months follow-up. The third is high sensitive when there is present neuropathy, vascular disease, and or foot deformity, and follow-up every 3 months. And very high risk group when there is a previous ulcer or amputation, and this is follow-up each month. This is test for monofilament testing for peripheral neuropathy. This is Turing fork for peripheral neuropathy. This is ankle jerk for testing peripheral neuropathy. The second, testing of vascular status by medial pulse, Doppler ultrasound, ankle brachial index, angiography, toe pressure, transcutaneous oxygen. This is medial pulse. This is ankle brachial index. And this is measurement of oximeter. This is measurement of toe pressure. This is oximetry measurement for peripheral arterial disease. First, we should be education the patient for lowering plasma glucose level, beneficial effect in reducing micro and macro complication, advise on diet and physical activity, advise overweight patient to reduce weight, give patient health education on foot care, nail cutting, treatment of calluses, and operative treatment. Next. This is a simple way. This is a simple way for how to explain the patient by simple language. Preventive foot care. This is taught by another colleague. An infection, one of the major threats in diabetic foot ulcer, it has potential serious complication because of its ability to destroy tissue. At the time of presentation, about half of diabetic foot ulcer, 60%, are clinically infected. This is potentially serious infection. Proceed about 85% of amputation relating to diabetic foot ulcer. The major predisposing factor to this infection, foot ulceration, which is usually related peripheral neuropathy, peripheral vascular disease, and various immunological disturbance. For treatment of diabetic foot ulcer and diabetic infection, early recognition, proper assessment, and promote intervention are vital. A combination of surgery and antibiotic. The aim of surgery is twofold. first to control infection, and second to attempt to salvage the leg. Food deformity resulting from surgery may cause re-ulceration with high morbidity. The surgeon must be possess understanding of the microbiology, pathophysiology, behavior of the infection, wound management principle, and food biomechanical, and also should be know the anatomy and surgical approach of the food. Infection is diagnosis in a clinical basis rather than microbiological lab or radiological ground. Subclinical course with absent or minimum sign and symptom, it may be sometime progress rapidly in days or hours. This is a classification for infection according to International World Group of Diabetic Foot or Infectious Disease Society of America. It's classified to mild, moderate, and severe according to superficial or deep infection, or present of sign and symptom, and present of systemic sign. The surgeon should be determine the need of surgery. Infection may require surgical procedure, which is range from drainage of pus, excision of infected and necrotic tissue, to revascularization of lower extremity and reconstruction of soft tissue defect or mechanical misalignment. The surgeon should formulate a strategy for eventual soft tissue cover, either by primary closure, delayed primary closure, secondary intention, or tissue transfer. Next. What is a benefit of debridement? To remove necrotic sloughy tissue and callus, reduce pressure, allow full inspection of underlying tissue, a drainage of secretion, and pus, simulation of healing by changes chronic wound to acute wound, also used for tissue specimen for culture. Next. If there is a doubt about the arterial supply to the foot, and if there is a realistic option for revascularization, this should be done before the amputation take place. How we should diagnose osteomyelitis in a patient with diabetic? Osteomyelitis is a potential complication of any infected, deep or large foot ulcer, especially one that is chronic or overlie bony prominence. We should do probe to bone by using sterile metallic instrument test for any diabetic foot infection with open wound. The most definitive way to diagnose diabetic osteomyelitis by combined finding of bone culture and histology. When the bone is debrided to treat osteomyelitis, you should be sending a specimen for culture and histopathology. Radical resection of bone leave no remaining infective tissue should suggest prescribing antibiotic therapy for short period of time, 2 to 5 days. When there is persistent infected or necrotic tissue, we suggest prolonged 4 or more weeks antibiotic cover. What is the urgent intervention? And this is mostly on the soft tissue. When there is infection and gas gangrene, when there is compartment syndrome, when there is necrotizing fasciitis, or when there is infection, plus infection, ischemia plus infection, this is an urgent, less urgent surgery with wound with substantial non-viable tissue or extensive bone or joint involvement. Diabetic foot ulcer frequently occur in weight-bearing area of the foot. Patients are insensitive due to diabetic neuropathy, lacking the sensory feedback. Relieving pressure facilitates healing by external mechanism or devices. The pressure offloading, it is meant to redistribute pressure. The most important thing of healing diabetic foot ulcer, which means neuropathic one, to eliminate pressure under ulcer. We can use all medication, all facilities. It is most important to get the pressure of the ulcer, and the best way by total contact cast or another by use removal device like removal cast worker. debridement in diabetic foot with peripheral arterial disease. First, a preoperative vascular assessment is mandatory. Local debridement before revascularization. If the wound is infective, we mean local, it is minimal debridement, while total debridement after revascularization to reduce or remove necrotic load, total offloading till wound heal. This is a case, next. This is a case of Charcot neuropathy. It is a condition causing weakening of the bone on the foot, occur in people with have a significant neuropathy. The bone are weakened enough to fracture, and with continue walking, the foot eventually change shape. As the disorder progressive, the joint could collapse and the foot take abnormal shape such as rocker bottom appearances. If left untreated, this destructive process lead ila deformity, ulceration, infection, and ultimately worse to amputation. Timely diagnosis facilitates treatment and decrease long-term disability. The best safeguard is high index of suspicion, especially in any diabetic patient with the swelling, warm foot, and present of neuropathy. This is a picture of Charcot with Charcot disease with ulcer. What is indication for conservative and indication for major? We mean by conservative amputation, it is mean minor amputation. It is amputation of part of the foot not affecting walking ability and no need to prosthesis. On the left, when there is good blood supply to foot but infected, small vessel disease and gangrenous toes, successful surgical bypass, neuropathic foot with little arterial disease, osteomyelitis with little arterial disease. To the right, when major amputation, it is amputation like transtibial, transfemoral, through knee, through hip, which need prosthesis. When there is wet gangrene infection plus ischemia, life-threatening sepsis, extensive muscle necrosis, revascularization technically impossible, bedridden patient, functionally useless limb. Next. A mistake in treating shortly in treating a patient with diabetic foot due to the insufficient training of the health care, suboptimal assessment, suboptimal treatment, failure to refer patient to a foot care team. Lastly, what is a Basra policy for amputation prevention? Clear diagnosis should be made in any foot, even in simple cases. Full vascular assessment, neurological examination, foot X-ray, microbiological testing. A major amputation should never be considered as a primary intervention in the absence of peripheral arterial disease. If peripheral arterial disease is suggested, revascularization should be considered before any amputation. Thank you.
Thank you very much, Dr. Abdel Hussein. We will again keep our question to the end of the session. So we are,
yes.
Yeah, Dalal,
I can.
Would you like to introduce the
Absolutely.
next speaker, please?
Yes. All right, we'll go ahead. Thank you, everyone, to our audience for being so patient. So Dr. Zahir is an associate professor of medicine at Bakkai Institute of Diabetology and Endocrinology, Bakkai Medical University, Karachi in Pakistan. He's the vice president of Diabetic Foot International, chairman of MENA Region Diabetic Foot International, project director of FED, which is Footwear for Every Diabetic, past president, National Association of Diabetes Educators of Pakistan, and the program director of Train the Foot Trainer in the MENA region. And he's the general secretary of Pakistan Working Group on Diabetic Foot. And he will be talking to us today about a proposal for data collection on diabetic foot in the IDF MENA region. Please, Professor Zahid, we look forward to your talk.
Okay, thank you very much indeed, Professor Jamal and Professor Nizar and Professor Abdul Basid and the other colleague to give me this opportunity to share my thoughts regarding the proposal for data collection in the MENA region. As we heard that the diabetes ulcer are increasing in numbers, and so is the diabetic foot amputation lower. Now, with this increasing burden of diabetic foot ulcer, the lower extremity amputation is now performed every 20 seconds, which is very pity in the fact that it was before 30 seconds, lower limb was lower limb amputation was performed before 2012. So, and if you look at this, the data by the David Armstrong and the colleagues, which shows the mortality and the direct cost of care for the people with diabetic foot complication are comparable to many malignancy, as shown by the AML. And this is, although an old data and extrapolation of the data, but it is really a scaring data for our region and the country of the region as well. So, and with the permission of our chair, Professor Nazar, I'm presenting this remarkable work which he has done by collecting the data and doing this survey in our region regarding the diabetic foot problems and the diabetic foot care facilities in the MENA region. I just summarized his survey, and you can see over here that 9 of 15 countries in the MENA region do not have or have a lack of data about the prevalence and the cause of the ulcer. And similarly, 10 out of 15 countries of the MENA region do not have an amputation data about the amputation rate and the foot education. And about the foot care facilities, only 4 of the 15 countries in the MENA region have more than 10 diabetic centers. And about the payment mode, most of the countries have a partial payment mode. And on top of all of these, we also do not have enough data about the diabetic foot infection and its outcome in the region. So we need a lot of data and a lot of work in the region, and scarcity of the data is one of the problems as a whole in the MENA region, as very rightly pointed out by Professor Nizar in this survey. And as we data and data and data, we hear so much about the data, and as the Carl Becker in 2012 in one meeting said the auditing should be the part of the organization of the diabetic foot care in any region, taking into account that the effort required for the data collection and analysis should be balanced by the expected benefit. And this is the importance of the data. And I'm sharing you a few things about how the data can help us. So the data help us to identify the problems, any problems. Data in journal can help to identify the problems. It helps to make the strategy about the problem, especially in our region about the diabetic foot problem. We can, if we have a good enough data, then we can make a good strategy and plan. And then, of course, with the good data, we can develop the theories and plan for the research as well in our region. And importantly, we can assess our functioning as well, how we are doing. That is the audit, which is one of the important point, as the Carl Becker pointed out in 2012 in a meeting. And nowadays, it is important to get funding for the project and so the data can help a lot for getting funding for your project as well. So, and this is I'm sharing with you our journey, 27 years of journey to how we collected the data. We started 27 years back when Professor Bassett returned back from the Nottingham, UK, and bring out many forms with him. And one of those forms has got a performer, has got the diabetes data collecting form and the diabetic foot collection forms. And we started this data collection from the very beginning of a start of our diabetes and the foot clinic way back in 1992, perhaps. And we have many barriers and hurdles during that period. And initially we doing on this paperwork, a lot of paperworks were there, and a lot of time was taking on filling out this performer. And with the passage of time, we got a computer, a PC, and then we had a software developed, and then now we have a full-fledged health management system, and which has got a diabetes data and the diabetic foot ulcer and prevention data, for more than 200,000 data we have currently. And with the help of this data, which we were able to have many studies in the diabetes as well as in the diabetic foot, starting from the single study center, reaching up to a multiple center oriented study and a multinational study nowadays. And now we are at the point of reaching to completing our diabetes registry of Pakistan with the type 1 diabetes registry and the type 2 diabetes registry already working, and we are in progression of developing the diabetic foot registry of Pakistan. So with this, I'm just sharing with you, which one of the project we completed in the recent past, the foot where for every diabetes a project, which is a joint project with the WDF, World Diabetes Foundation, and the Buckeye Institute of Diabetology and Ecology, which is part of the Buckeye Medical University. And in this project was presented, the data was shared in many platforms internationally and locally in the MENA region as well. And in this project, we developed 10 project centers all across the country, and every project center has a risk assessment clinic, and we have a dual reporting system in this risk assessment clinic, because some part of the country do not have the facilities of the PC and the computer. So we had the performer based data collection, and in few center we have that software developed for the diabetes risk assessment, depend upon the IWGDF 2015 guidelines. And then we created, every center created a focused awareness on the diabetic foot care and the footwear. And every center have got a training. We did the training of the cobblers, the street cobblers. We trained them, and the foot care assistant, because we do not have the podiatrist in the Pakistan, but we do have the diabetic foot care assistant, which is well recognized in the IWGDF and IDF as well. And we trained them for the offloading and the footwear manufacturing Ben Nelson from the Denmark give this 2 weeks extensive training on the footwear offloading and the manufacturing. And then we have the facilities in every center. We have the facilities of manufacturing the standardized, low cost and durable and acceptable footwear in 10 center all across the Pakistan. And I'm sharing this with you, this the flow diagram, how we collected the data, and we collected the data from all the center, that is the 11 center every month. We analyze these data, those data, and then reported to the WDF every 6 months. We examine about 150, more than 150,000 people, and divided into 2 groups. Those with having a feet at risk, more than 136,000 people, and those with having an active foot ulcer, more than 14,000 people. And this is the risk assessment according to IWGDF 2015 guidelines. And then if you look at the right side of the risk screen, the at risk people, those who comply and fully follow up, about 6,694 and 47% of the people. And you can see the results. Those who develop the first or the recurrent ulcer, only 252 people at risk develop. That is 3.76% of these people develop first or the recurrent ulcer during this 3 years time. And you can see the risk of the category who use this footwear for more than 80% of their working time. And on the other side of the screen, on the left side of your screen, you can see the ulcer data, and you can see at the end the orange boxes, those who completed, those who comply and follow up and using these offloading therapeutic footwear and completely healed, was 73% of them completely healed, while those who are not completely healed, 41%. And these are the UT grade of this those people who with the ulcer. And this is the WDF reports that the footwear for every diabetic protects feet across the Pakistan. This innovative project has overcome the challenges to produce low-cost, long-lasting footwear for thousands. Now the project team, we hope to share this model with the other side, hoping that we can share in the MENA region and the countries of the countries of the globe. So my proposal, or our proposal, our team the stream proposal has got 2 proposals. One is the development of a software for the collection of the data in the MENA region, and the other proposal is the regional research proposal as a part of implementation of data collection in the MENA region. So I'm just giving the thoughts. These are the initial thoughts, of course. So the proposal 1 for the data collection, we suggest and request to develop a simple, user-friendly software dedicated to collect foot data which have a uniform reporting and key variables. This software can be used in every country, or even every clinics of the country or of the region for that purpose, or if possible, it can be incorporated in the pre-existing system. And the country association of the IDF MENA region or can help to disseminate and implement the use of such a tool for the data collection in their respective country. And this can be started in the MENA region as a pilot project. And one of such software has been developed by the UNFM. Probably Professor Nizar, we must be knowing because it's in this university in France, in collaboration with the DFoot International. This is called the DFoot data. This is a very simple data which is directly on the USB key, and this node need no installation on the computer and may be used on the different computers without an internet connection. And you can exclusively enter data on the USB itself and keep the key in a safe place, and a simple to use, user-friendly data. I'm not going into the detail of this, but it is available free of cost. You have to, I think we can collaborate, we can produce some collaboration with the DFoot International and UNFM for collecting such, for using such a tool in our region as well. And the second proposal is the proposal for a regional research proposal, which is as a part of implementation data. And when we talk about the research proposal, and so we need to consider these 21 commitments of which are reported by the William Jeffcott and the colleagues in 2016 regarding the high quality research which can be done in the region as well and in the country, considering these 21 points before planning a research. So, and he also addresses the key variables, if you can, key variables regarding the prevention and the prevention and what are the key variables in different studies and the research we can use to have a good quality evidence-based research. So I'm just sharing an initial thought. This is not in the final data, not a final protocol. Of course, it needs to be discussed, and we're just sharing this. We need to have an research to identify the feet at risk and to see the effect of offloading with the footwear in the moderate and the high risk feet. This is according to the IWGDF 2019 guidelines, which is just a little bit different than the 2015 guidelines. And with the moderate, means there is no ulcer, of course, no history of ulcer, no amputation. So you are taking the, but they all have the neuropathy. So they therefore having at risk of developing the foot ulcer. And as Professor Bolton pointed out, that the people who have the risk of neuropathy, every 1 person in 20 can develop a foot ulcer. So this is a preliminary or initial thoughts, and we can discuss later on the method. And this is the data, which this is the similar project which we have done as the diabetic foot for every diabetes in Pakistan, and we can replicate and implement this data collection and the implementation of offloading techniques of footwear in the region as well, in different parts of the region. And in countries where the footwear is not available, the training program can be conducted to the cobbler or the diabetic foot care assistant for the offloading and the locally made footwear. So I'm not going into the detail of the methodology, but the one point which I like to share is that the patient with diabetes who are not willing to use prescribed footwear but regularly following the clinic will be taken as a compare group, and a uniform data collection is required via pre-designed software. We need to have designed a software for data collection or a performer, and each country should collect the data and submit to a central collection station quarterly anonymous. Of course, this you may not shows the identity of the patient. And so in summary, the data collection is important and need of the time for planning and present working and future preventive and management strategies. A data collecting tool or a software can be developed and implemented as a pilot project in the MENA region under the umbrella of IDF, and a research project in the region can be initiating regarding the feet at risk, which can help to plan the further preventive study, for example, offloading footwear and the other things we can plan for that reason. So the final take-home message, as the Professor Bolton is pointed out in this holy book for the diabetic foot in diabetes, the continuing audit is essential for the delivery of optimal care of diabetic foot ulcer, and data collection is the key. Thank you very much for your patient listening.
Thank you very much, Dr. Zahid. This is very nice and clear presentation about data collection. Maybe we are going to consider all this proposal in our task force. So we have to discuss more on details of everything. It's very interesting. I like it. Now we have, if you allow me, we are moving now to the question and answer session. And we have 19 questions. We can start with that. Dr. Dalal, would you start with the first question, please?
Yes, perhaps I will direct the first question to Dr. Zahid Mayan. Impressive work from our colleagues in Pakistan, always very impressive initiative, collaborative and collegial. There is a question about, thank you, Dr. Zahid, can we use the project like International COVID and Diabetes, the DIA project?
I really don't know the right answer, but of course any project can be started provided you have the right protocol, and as defined by the William Jeffcoat and the other colleague, that you have to have the right ingredient on that project and the right answer to the right question, and what are the questions you need to answer. So that is very important for every project to think about and to start with.
Okay,
Thank you so much.
I can answer to the second question because it is in French. Maybe I can do that, Dalal.
Yes, I don't know French.
To answer to the, so maybe I can do that. The question is, do we have necessary put patient with diabetic foot in insulin therapy if they have any ulcer? The answer is no, because if your diabetes is controlled with oral treatment, it's not necessary to start insulin at all. Take care of diabetic foot, don't need insulin therapy. And if they will control, adding insulin will not add any more benefit for this patient. So next question, Dalal.
The audience are asking about the sign that is most specific for a diabetic foot. So maybe Dr. Hanan, you can tell us? What's
Diabetic foot is not one entity. Diabetic foot includes neuropathy, refractory disease, infection, deformity, ulceration, Charcot, and each one has its own early manifestation. So if he means early manifestation for, and I think he is, for diabetic foot ulceration, that goes with what Professor Bolton said about foot screening and risk categorization according to the finding. This is the best thing anyone can do for his patient.
Okay. Thank you. There's a question from Dr. Al-Basit is asking, how do we need in our region to prepare new guidelines, or we have to go directly to implementations, programs, whatever, step by step, or data collection? Well, already I answered to this question in my introduction, saying we are not going to write again the guidelines because the IDF guidelines are there and they are adapted to be implemented everywhere. So I agree with Dr. Abdul Basit. We are going to practical programs or initiatives, whatever you call that. Then a question again to Dr. Hanan. What is the question here? What is about Charcot's foot? Is it chronic or acute? This is information. This is acute or chronic disease. And what about diagnosis and treatment? I believe you answered to all that, but if you would summarize that in 2 words about.
Yes, I would like. Yes, acute Charcot needs high degree of suspicion. It's mild warmth in the feet, swollen and red sometimes, with usually history of non-significant trauma. The patient usually denies history of trauma. And this acute Charcot is very difficult to diagnose because the physician usually think of cellulitis, ankle spare, uric acid, anything in the foot except for acute Charcot, because not a lot of people knows about acute Charcot. So if we put it in mind, MRI is diagnostic, and if it proves to be acute Charcot, casting is a gold standard for management of Charcot. If we cast the patient, then we preserve the limb with its shape without any deformity, and everything is going to be back to normal feet. But if neglected and the patient continue walking on it, not knowing that there is acute Charcot, inflammatory position, state of inflammation is usually going on, we are going to end in the ugly, deformed feet of chronic Charcot that we do not guarantee our salvage to this foot in any center. So diagnosis of acute Charcot should be our utmost important. But chronic Charcot, every center is going to know that this is Charcot.
Okay, thank you. Dr. Dalal, you would like to continue the question,
yes,
please?
Maybe we go to Dr. Amal. I think in your talk you've mentioned some patients might be using herbal supplements, and there's a question about that. What is the mechanism of Capex extract to decrease the diabetic foot symptoms? I personally don't know what that is.
Who would like to answer to this question? Dr. Amal?
Right. There are some studies on this. I'm really not acquainted very much with this issue, but I can refer the doctor who asked this question to look at the PubMed. I just found one study. I'm sorry, I'm not acquainted with this herbal medicine.
Actually, what we have about that, we know it has been used for many years. There is no clear mechanism for this kind of herbs, but it's not recommended. It's not in the guidelines now. So maybe we have to preserve it for small cases with pain. It can decrease suffering from pain and diabetic foot neuropathy. But it's not recommended, and it's not in the guidelines now. We do not know a lot about the mechanism of this. This has been used for many years, 1 decade ago, 2 decades ago, but not anymore now. This is my experience.
Dr. Nizar, is this the same as capsaicin? No?
Yes, it's capsaicin. This is the capsaicin, yes, of course.
Okay. So it is used, now there are patches that can, as you said and alluded to, it can decrease the severity of pain.
Yeah.
Not in all patients. In some,
it's not recommended, not really efficient. For some
Okay.
people, yes, but for others, no.
Yes, but
Yeah, can I say something?
Yes, please, good.
Yeah, there is some limited data. I think we need to make sure these things to our audience that we're considering the anecdotal use of everything. So we need to recommend the evidence-based medicine, and the evidence is limited now for the capsicum, and we are having the other good medicine in the armamentarium of using for the pain symptoms. So I don't think so.
Yeah. Okay.
I can elaborate on this point more. As a herb, we cannot advocate the use of it because maybe the patient will apply too much, or this can hurt the heart. But there are patches, and these patches are approved in Europe for use for diabetic peripheral neuropathy for the painful type. So the patches, can be used. But
the next question is related to this one. As diabetologist, what medication to prescribe for diabetic neuropathy, and what is the starting dose, and how to follow anti-titrate? Dr. Zahid, are you going to answer to this question, please?
Yes, a short one. Yes, there are some first-line drugs which need to be used. Duloxetine is one, the pregabalin the other, the gabapentines are the one which are again the first-line drug, and then there are second-line and the third-line drugs which can be used so after. And the key is to start with the minimal dose to have the minimal side effect profile, because every drug has got the side effect, especially these the neuropathic pain reliever. So to start with a small dose, and then you can increase the dose 2 to 4 weeks times, and then at the point where the patient gets so there is one study, the combo DN study, which is the combination of the duloxetine and the pregabalin, and in a higher doses, the pregabalin has got the more benefit as compared to the duloxetine, but in combination, the combo DN said there is no benefit. So you can use together, and you can use one by one, and once you can use one drug, and then you can use the other drug, and then you can combine the two drugs together as well.
Okay, thank you very much. Thank you. The next question in French. The question is talking about the French people who are speaking French, because they cannot follow us in English, and they are asking to organize a webinar in French. Maybe we can do that if there's a lot of speakers for French language. Okay, we can consider that for the future. Next question, Dalal, please. Also in French also. Oui, surveillez simplement dans votre nom. Oui, Iman Joseph. Oui, surveillez-le de quoi? Bon, je sais pas. A question to Dr. Abdel-Hussein. I believe this one. Is there any need for MRT for diabetic foot?
Sometime. We can, best in deep-seated infection, best we used a new technique, ultrasound. Some ultrasound to detect this is non-invasive, easily, which need a specialist. When next for MRI for diagnosis a deep-seated infection. Yes, there is a rule to use MRI in some cases.
Okay, thank you. Next question.
Then the next question is the best treatment for tinea pedis between toes using antifungal powder or creams, and why?
who is
Dr.
willing
Hanan,
to?
would you like to take
Personally, yeah. Personally, I would like to use the lotion, because the terbinafine is present in a lotion, while the cream, while the patient is macerated or there is some wetness, the cream might not be working. But there is some forms of cream which are hydrophobic. It could be used. The powder is better for prevention after cure of tinea pedis. Then the patient better to use the powder for time after that, not to have recurrence of the tinea pedis. And sometimes we use systemic also when it is severe. We use systemic. Terbinafine is the first also, Lemezi, and fluconazole is also used as weekly dose for 6 weeks, sometimes depending on the severity. But
okay, thank you.
We need a big but, as Professor Bolton said here, we need a big but. Prevention of tinea pedis is much better than treatment. If the patient used to dry in between the toes after each wash, is going to be much better than having tinea pedis treatment.
Okay, thank you. Next question. What about using antibiotic for all cases of diabetic foot ulcer?
I can answer this question. Not all cases of diabetic foot ulcer, it is infected. About 50 to 60%. We depend on the clinical basis to diagnose infection. If there is infection, we, for mild infection, and we can use oral antibiotic, and for moderate and severe infection, we use debridement, is a minimal surgery plus antibiotic therapy.
Okay, thank you.
On the present or not infection, and depend on the severity of infection, mild, moderate, severe.
Yeah.
So there are several questions for you, Dr. Hanan, all about the step-by-step program. You inspired a lot of colleagues. Dr. Basil Al-Yusuf from Kuwait is asking for your contacts. Maybe through Amber we can, if with your permission, share, so that they can collaborate and get more ideas. And there's also a question if this setup is done in primary care or secondary care.
It could be done. I have sent him my email directly now, and this is one of the success that we have motivated other people not interested in the foot to become interested. And the step-by-step could be present in any place. We have put in step-by-step, we choose the physician and nurses from areas where diabetes setting is seeing a lot of patients, so he can serve. And if a primary care physician or primary care setup is seeing a lot of diabetes patients, why not?
Okay, thank you. The next question, what about using Carbotherapy in management of diabetic foot? What is the Carbotherapy? What is the Carbotherapy? I don't know.
Yes, I can to Dr. Hanan, to me.
Yes, please. Go on.
This is no evidence base to use Carbotherapy in the treatment of diabetic foot. It is only I use it. In many cases, the result is not so good. I think this is of the benefit only for dressing, and for patients dressing, frequent dressing. I think and fellow, this is more than taking from Carbotherapy. The effect on CO2 on the skin, not so much effect on the increase the blood supply to the area. I think this is all the type of treatment. This is my opinion, and there is no evidence base to use it.
We don't use it at all in Europe, at least in France, in our center. I don't know, maybe some other countries, because it's not approved.
I think in Germany and Japan, use frequently.
Yeah, great. The next question, Dalal, do you have any more questions?
There's a question about Any contraindications for using SGLT2 inhibitors in diabetic foot active infection?
Well, the answer no. There is no contraindication.
Only canagliflozin has proved.
Anybody want to go into
application?
details for the question?
Yeah.
I don't know.
Only canagliflozin has some bad news as regard to the patients with higher rate of amputation on canagliflozin, but this has not been proved by the other group of SGLT2, and canagliflozin is no more blamed. I think there are a lot of results on that done. Yeah.
This was only one study 5 years ago, and the next study coming in ESD 2 years ago, showing that there is no any harm using these drugs is SGLT2 for diabetic people, and there is no any increase in amputation or low limb in this patient. So no contradiction. The next question about using honey for treatment of diabetic foot. What is your experience, Dr. Hanan?
About the use of? I didn't hear you.
Honey.
Yeah. Honey is having evidence on the management, and it's quite nice for our countries with very expensive other dressing. Sometimes is working, but it needs to be different than the honey used. It needs not to be heated before, not to be packed for dressing, not for eating, and so on. So some of the honey preparation present in Egypt is combined with some growth factors, and it is present in patches, and it was giving good results with us. We recommend it, yes.
So, but
certainly
make sure
not for all cases. It depends on cases.
Yeah.
But make sure that this is not the honey which we are taking with the food. Not this one.
No, not this one.
Yeah.
And not all cases. Some cases you be careful.
This is for even for not infected cases. When there is clean wound, it is in hand healing by prepare a moisture media for fibroblast.
And growth factors, yes, of course. But if there's any infection, maybe we have to be very careful about that. Yeah. Okay. If you agree, we can maybe stop there. We are behind our time, and I believe we still have any questions? No?
I think that just there's a common theme among questions. There is a lot of, as highlighted by our speakers, gap in knowledge in the day-to-day management, what antibiotic to give, what antifungal to give, how to examine. So we need sessions, more sessions, of course.
Okay, great. At the end, let me thank you all, my co-chairman, Dr. Dalal from Bahrain, and all speakers from Pakistan, Egypt, and Iraq. And also we have our Dr. Amal from Jordan. All colleagues are really appreciated by this presentation, and we hope to see you again on this Pro Circle, probably to talk again about diabetic foot, which is, as you see, is a huge issue in our region. Thank you again, and have a good day.